Hello, everyone. Thanks for joining. Today's session, we're going to continue on talking about urgent eye care, and we're going to focus on lid lacerations and orbital fractures. So, in today's session, we're kind of covering trauma, and trauma is very, very broad, and quite a lot of major trauma that comes in some way involves ocular injury. 1% doesn't sound like quite a lot, but when it does happen, it's very important. And these patients are usually sometimes most concerned about their eyes, and the injuries that they can suffer are life-changing. And knowing how to manage people swiftly and correctly can really make a long-term difference to these patients. So it's important to sort of have a good idea of how to manage these patients and regularly remind yourself how to manage because you're not going to come across them often. But when you do, you won't necessarily have a lot of time to think about what you're going to do. And it may be at times of the day where you don't have access to a lot of seniors. So it's always worth sort of reminding yourself what you do in patients that come in with these sort of injuries. We're not going to talk about globe injuries today. I'm saving that for a separate session. But today we're going to specifically focus on lid lacerations and orbital fractures. So starting with lid lacerations, these can really range in terms of how the extent of the injury and the urgency with which you need to manage them. So you can see in that top right, that's a very superficial laceration, non-involving the lid margin. That probably doesn't even need stitches, maybe a couple of steri strips, some chloramphenicol ointment can probably manage that. Whereas the injury in the bottom right-hand side there is obviously much more extensive. And when you're involving the margin of the lid, when you're involving the canaliculus, there are some careful considerations to make when you're approaching these patients. So, starting off with the superficial injuries, like I said, simple scrapes, grazes to the skin, these can sometimes just be left to heal with secondary healing. So, you just let it epithelialize. Some steri strips can help close the injury and allow things to heal. And some chloramphenicol ointment can act A to prevent an infection, but also the ointment itself can moisturize the skin, help with healing, reduce the risk of scarring. And once the skin has actually healed, advising these patients to moisturize can actually really help with avoiding the scarring long term. And especially if you're looking at the lower lid, you want to try and avoid lots of scarring because you can then end up with a cicatricial ectropion, for example. And I've spoken about that in terms of lid malpositions and how to manage them. When it comes to the more severe injuries, you need to be careful really with your assessment. So you want to kind of look at where on the lid margin, what's involved. Does it kind of involve the canaliculus or is it outside of where the puncti are? Is it more lateral to that? Is there actual any tissue loss? So if you try to actually put the lids together, have we lost tissue as a result of the injury? And if we have, how much tissue have we lost? Because that's going to be important in terms of whether or not you can manage these patients acutely or if they need a bit more of a careful reconstruction. Then obviously you're going to want to properly assess the eyes and you're going to take a front to back approach, looking at your cornea, your conj, looking at the anterior chamber, your iris, your lens, looking at the posterior chamber, and thinking about whether or not there's any ocular injury at all. You're going to look at the patient's vision, check their pupils. You're going to assess for any signs of an orbital compartment syndrome, for example. Look at their ocular movements. Is there any restriction? Is there an RAPD suggesting that there's a problem with their optic nerve? Do they have a color vision issue, a drop in their acuity? So really take a careful assessment of the globe and make sure that any of those injuries haven't extended to the back. And what you want to consider and what can sometimes catch you out are things like foreign bodies. So sometimes foreign bodies can go through the lid and lodge themselves either into the globe itself or even behind the globe. And you may not know that those foreign bodies exist at first assessment. So having some sort of imaging to help you, like a CT scan, can be really helpful. Then obviously sometimes these injuries are also combined with orbital fractures. Where is the fracture? And we'll talk about that later on in this session in terms of how you manage those and what fractures sort of need urgent management and what fractures can be monitored. And involvement of the canaliculus is going to be important in terms of how you then repair in the kind of primary repair of the lid. So look at the punctum. Is the canaliculus involved? Is the injury medial to the punctum? Are you concerned the canaliculus is involved? And actually, which canaliculus is involved? If it's the upper canaliculus, sometimes in urgent situations, the repair isn't, you can sometimes afford not to repair the canaliculus if it's the upper punctum, because that, usually does 10% of the drainage. But really, you ought to try and repair these puncti and the canaliculus properly, regardless of whether or not it's the upper or the lower. And then also, what's their tetanus status? Have they had a recent jab? Was the injury with a metallic, sort of rusted foreign body? Do they need a tetanus jab as a top up as well? And a lot of the time, your medical colleagues can help you with this sort of thing, but it's always worth remembering them because sometimes isolated lid or globe injuries may directly come to you with no other involvement. So it's important to remember the systemic aspects of these injuries. So repairing lid injuries, a lot of you will have your own simulated sessions, but I just thought it was worth just as a reminder, you want to really be careful with repairing these injuries because you want to prevent a notch because that notching will impact the closure of the eyelid. It will impact how the tears sit on your ocular surface. So, these are patients that can potentially end up with an exposure keratopathy if they're not treated properly. They may end up with problems with epiphora because the tears aren't draining properly. So be careful with repairing the lid. And there's a very set sort of way to repair it. And the three main steps are essentially you're going to insert a gray line suture. So that's kind of coming in. I'll use my sort of arrow here. So you're going to come in from the top of your kind of lid margin, come into the gray line and out again. And you're going to sort of create a loose suture. You're not going to tie this. You're just placing that at the start to make sure that your lid then closes and is opposed properly. You're then going to start inserting some partial tarsal plate sutures from the front. So coming in from the front, underneath that skin, you're going to place some deep sutures that go through that tarsal plate. You're not going to go full thickness because you don't want those to sort of protrude onto the bulbar conge. You just want, sorry, the tarsal conge. You just want it to go through the tarsus and close that tarsus. So you'll place a few partial thickness tarsal plate sutures with an absorbable 5/0 suture. And then once those sutures are in place, you can then tie the gray line suture and knot that. And your gray line suture might be with something like a 5/0 silk. The ends of that gray line suture you want to keep quite long because if you make them short, what can happen then is that they will bother and they'll irritate the ocular surface. So if you make them long and then fold them down onto the lower lid, your skin sutures that you're going to place with something like a Prolene can then keep that suture in place and keep it like running along that lower lid. And the skin sutures usually, what I've been taught is to try and use something non-absorbable. The way sutures absorb is by, it's inflammation and the body is essentially eating that suture and that's going to cause scarring. It's going to slow down healing. So if you have a non-absorbable suture where you keep it in long enough for the skin to start to heal and for the skin to close and then just take them out so that you can reduce the amount of inflammation, bearing in mind that you will have some because of those tarsal plate sutures anyway. So a 7/0 Prolene, for example, that you take out after 7 to 10 days, remove those non-absorbable sutures, and then you can see them again at about 2 to 3 months to make sure that everything is healing nicely. But out of hours, if you're repairing these lid injuries, it's important that you take this sort of stepwise approach because you want the lids to close properly along the x-axis, along the y-axis, and also along the z-axis. So you really want these to heal well. So a gray line suture first to close that gray line and make sure that your lid is opposed properly and that your meibomian glands are all lined up. Then those tarsal sutures and then the skin sutures to close everything up. A quick comment on canalicular injuries. These really ought to be repaired very urgently. And the reason is if you're sort of waiting more than 24 hours to repair these injuries, the scarring has already started and it's going to be really difficult to actually keep that canaliculus open. So the lower canaliculus, like I said, especially, it's really important to try and repair these urgently. And the way you repair them is essentially by inserting some scaffolding really into the canaliculus. So if you think about it, the lower punctum will be somewhere here. You'll insert this stent into the lower punctum. It will come out through the lid, and then you want to insert it into the other side of the canaliculus. And that can be really difficult to find sometimes, especially in quite irregular injuries or in children, for example, where these things are already quite small. And this picture here is a picture of what we call a Mini-Monoka stent, where it has a bit of a plate plate on the end. So this end will go into the punctum, it will go through the canaliculus. You'll try and pass it through into the other canaliculus. And then this is a plate here, which can sometimes you can apply a suture to it so that it stays in place and then it keeps everything closed. So the reason you're putting this is, and essentially, when you then do the lid repair, there is a piece of silicon that is running through the canaliculus along which the healing can take place and the canaliculus remains open. And without that, you are almost certainly going to essentially cause a canalicular blockage, in which case these patients are going to need canalicular DCRs later down the line. So really do kind of consider your canaliculus when you're repairing these injuries, and really do try to repair it if you can, because you're essentially potentially avoiding the patient having to need a DCR. And there's a session on the channel already about DCRs and blocked nasolacrimal ducts, which you can look at as well. With tissue loss, it's important to try and figure out how much tissue loss has happened, if there has been. And if you think about the tissue loss, it's very similar to when you're thinking about excisions of masses, for example. So if you have less than a third of the lid missing, usually you can just directly close the lid with no problems. But if you've got more than that, you sometimes need to consider whether or not you need extra tissue. If you just need a bit more laxity in the eyelid, what you can actually sometimes do is, just by doing a lateral canthalisis, you release that tendon and actually you release some of the laxity of the lid, and you can then just directly close in the acute setting without the need of a reconstruction. But if you have quite a lot of tissue loss, you may actually need a much more planned reconstruction. So in these sort of patients, you may want to just get rid of any sort of dirt, clean the wound, patch it, put something on there with a gelinet, for example, lots of chloramphenicol ointment, and then actually bring them back in to then during the day to then discuss with the oculoplastic colleagues more of a sort of careful reconstruction, either with a flap, for example, a glabella flap, for example, or actually more of a graft with something that's taken from your pre or post auricular tissue, your clavicle, or something like that. And there'll be a future session where I actually look at specifically masses on the lid and reconstructions. But just bear in mind that if you have lost a lot of tissue, then actually these are patients that may not be able to be directly closed in the acute setting. So a reconstruction may be necessary. But if you are on that sort of margin of maybe just a third of the tissue lost, but you have a bit of tightness in the lid, you can release that lateral tendon to essentially bring the lid in and allow you to close it in the acute setting. So moving on to orbital fractures, essentially orbital fractures can happen from high impact blunt injuries, and they can fracture any of the orbital walls. What tends to happen is that you basically have an injury to the face that is larger than the aperture of the orbit. So not something like a squash ball, more something like a fist or a wall, for example, or a car crash injury where nothing actually enters the orbit, but it's a blunt injury from the front. And then that impact, essentially the globe doesn't absorb it, it then goes to the orbit, and then you can have what we call blowout fractures. And most commonly, they'll happen along the orbital floor. Any wall can be fractured. The lateral wall tends to be the hardest to fracture because it's by far the thickest. And just bear in mind that your medial wall and your roof are both communicate with the CSF. So you can sometimes have CSF leaks as a result of these, and a risk of meningitis and encephalitis. So, bear in mind if the orbital roof and the orbital medial wall are fractured, do make sure that these patients are properly taken care of. But most commonly, you're going to come across orbital floor fractures. When you assess these patients, it's very similar to your lid injuries. You want to make sure that you're doing a thorough ocular exam, that you're checking whether or not there's any globe injuries. These are patients that may have evidence of blunt injuries, which we'll go through later on a different session. But things like a hyphema, for example, disinsertion of their iris, a cleft, for example, something that can quite typically happen with blunt injuries. Check your ocular movement, because they can have restriction of their muscles as a result of sort of trapdoor injuries. Imaging can be really helpful to help distinguish between sort of subclinical fractures, things that won't necessarily have a lot of symptoms, but the CT will show you that there is a fracture. And bear in mind that these are patients that are going to come in potentially with other forms of trauma. So get a systemic review, make sure that the patient doesn't have any signs of any other injuries around the body, any sort of abdominal pain, any problems with their neck movement, any headaches, any sort of other fractures that would need treating. And the extent of the injury and your symptoms really are what determine how urgently these orbital fractures are going to be treated. And depending on where you are, orbital fractures are either going to be treated by the orbital team from an ophthalmology point of view, or they'll be treated under the MaxFax team. And that all just depends on how the service is set up. But ultimately, the indications for urgent management and for early intervention depend on really the extent of the injury and what symptoms the patient has. So most commonly, like I said, you're going to come across orbital sort of blowout fractures of the floor. And the features here, you're going to patients are going to come in with some swelling, some bruising, they may have some surgical emphysema. You may feel that sort of gas along that cheek. They may have some anesthesia because that inferior division of the optic nerve sort of runs along the inferior orbit. That can sometimes be damaged, so you might get some infraorbital anesthesia. They may have enophthalmos because our orbital floor has gone, so their eye starts to sink. Double vision because of that restriction of the inferior rectus, and any associated injuries as well, because, bear in mind that these are patients that are coming in with trauma. And the management, like I said, will depend on the extent of the injury. Generally, most of these patients are going to get antibiotics because you basically have an opening between the orbit and the maxillary sinus, and your sinus is going to be filled with muck. So you want to make sure that these patients are systemically treated with antibiotics to try and avoid the sort of orbital cellulitis. You're going to try and avoid nose blowing for a few weeks, some ice packs to help reduce with the swelling. And the surgical intervention depends on a few things. So the smaller injuries with less than 50% of the orbital floor, no sort of diplopia, they just have the swelling around the eye. These are injuries that can usually be treated conservatively. So you monitor them, you keep them coming into their clinic, you wait for that swelling to settle down, and these are fractures that can heal by themselves without any intervention. The indications for actually taking these patients to theatre immediately largely basically are only your ocular cardiac reflex. So patients who have persistent bradycardia with movements because of the ocular cardiac reflex, or trapdoor fractures in children. And I'll talk about what those mean. And then finally, significant asymmetry. So if there's a lot of asymmetry of the skull because of what's happened with the orbital floor, then these are patients that are going to get more immediate surgical intervention. The majority of people who get surgical intervention, however, it would be a sort of early surgical intervention within 2 weeks, but it wouldn't be immediate because you wait for some of the swelling to settle down before you go in. And these are typically the patients who are going to have some entrapped orbital contents, probably a muscle, and that will probably cause a lot of diplopia. And specifically, it's the diplopia that's within the central 30 degrees of your vision that we care about in terms of how urgently we intervene. If the diplopia is further out into the periphery, that's usually not because of any entrapment of muscles, but because of just restriction due to the inflammation. So you can wait for things to settle down without the need of surgery. But significant diplopia in the central vision, a fracture involving more than half of your orbital floor, and a significant enophthalmos of more than 2 millimeters. These are all patients that are going to sort of be treated with early surgical intervention. Interestingly, I think when a study that looked at those that had an ophthalmos of above 2 millimeters, I don't think their results actually differed whether or not they were treated at 2 weeks or 6 weeks. But generally, currently, the guidance is if you have entrapped orbital contents, significant diplopia in the central vision, a fracture of more than 50% of your orbital floor, or an ophthalmos of more than 2 millimeters, these are patients that meet the criteria for early surgical intervention within 2 weeks of their initial injury. You wait for the swelling to come down slightly, but then you go in to treat that fracture. And like I said, that's either going to be the orbital team or a MaxFax team, depending on where you work. I'll comment on trapdoor fractures. What these basically are, it's essentially because of elastic bones. So they typically happen in younger children. You won't really see these in adults very often because in adults the bones are much less elastic. Whereas in children, where the bones are elastic, they essentially open up, the muscle contents come through, and then the elasticity of the bones traps that muscles and brings the bone back into a normal position. So actually on a CT, it may look like there's no fracture. So the CTs can sometimes be a bit misleading. And what you might find is this sort of white eye that's restricted, and that's your sort of, the alarm bells are ringing in a child like that. So if you look at this picture, this is a child who is trying to look up at the moment, and that left eye is looking up, but that right eye is blocked into that position because that inferior rectus is trapped. So this is a red flag, and a child like this with a white restricted eye in the context of a trauma is probably a child that would get urgent surgical intervention to try and treat that orbital floor fracture because that's an entrapped muscle that we definitely can't keep there. When you're looking at other orbital wall fractures, you know, the roof, you just need to be aware of CSF leaks. They're not usually significant from an ocular point of view, but these are patients that are going to, you know, probably need to, you know, close monitoring in case they develop something like a meningitis. A medial wall fracture is usually seen in the context of an orbital floor, so we've spoken about the management of that. And like I said, the lateral wall fractures are quite rare because you really need a significant, extensive injury to break that lateral wall. So these are patients who are going to probably have much more extensive injuries and have the entire trauma team involved with their management. A comment on the tense orbit, because patients who come in with orbital fractures or trauma can have retrobulbar hemorrhages. There are obviously other causes of a tense orbit, things like infections, inflammations, and we'll talk about those when we talk about orbital cellulitis, for example, or orbital inflammatory syndrome. But in the context of trauma, a retroorbital hemorrhage can really kind of very quickly turn into an orbital compartment syndrome. And these are patients that are going to have intense pain, lots of proptosis, swelling, and bruising. They're going to have restricted movements because of those muscles. They may have a raised pressure. And they'll have signs of optic nerve compromise. So reduced colors in the early stages, that's quite concerning. Maybe an RAPD, reduced acuity, reduced fields. And these are all things that are going to direct you towards wanting to do an emergency lateral canthotomy and a cantholysis. Now, obviously, this as a procedure is a procedure that any emergency doctor should be able to do because it's an emergency treatment. It shouldn't wait for someone to come in. So, you need to know how to do it. And this is something that really ought to be done immediately if there's any concern about an orbital compartment syndrome. So I wanted to kind of talk about how I have done this in the past and how I think works well in the traumatic setting. Because when you're doing a canthotomy cantholysis in a kind of controlled setting in surgery, it's a very different procedure. There's not a lot of swelling. Your patient is very calm. Your patient is not in a lot of pain, and it can be a very different experience doing a canthotomy cantholysis in the urgent setting. So what I have found has worked quite well is really taking some time to prepare the patient is really helpful. So getting good pain relief, good local anesthesia into the area, which itself will be really painful, but get plenty of local anesthesia into the area. Maybe some so try and get lots of lidocaine, for example, that works quickly and numb the area really, really well. You then want to also consider sedating the patient. I've done this in the past and it works quite well. If you're in an A&E, if you've got some doctors there, if you're not comfortable sedating the patient, a bit of diazepam or a bit of midazolam can actually help sedate the patient, make them much more comfortable for the procedure. Because believe me, that local anesthetic, despite you putting in some, it is really not going to work as well as you might hope, and the patient is still going to be in a lot of pain. Trying to make that patient more comfortable is really helpful for them because this is already a traumatic experience, and it's also helpful for you in order to try and get this canthotomy cantholysis done efficiently, because having the patient writhing around in pain can really delay things and make things much less efficient. So having them calm can be really helpful. The last thing in terms of preparing the patient is if you get a straight artery clip and you literally just insert it to the side of the eye, straight down towards your orbital rim and clamp down. Really clamp down and leave it there for a good 30 to 60 seconds. That can really help you when it comes to actually creating the canthotomy. So everything is really swollen, everything is really bruised and ecchymosed, and getting scissors directly in can sometimes be really difficult. So using an artery clip, clamping it down and leaving it there for 30 to 60 seconds can really tighten everything up and give you a much easier access with the scissors to actually then cut open your doing your canthotomy. So that first step after you've clamped is a canthotomy. So you're basically cutting down 1 to 2 centimeters right down to the orbit and releasing that lower lid. And then you're doing your cantholysis. So you're going to retract the lid and you're going to use those scissors to essentially cut through that inferior lateral canthal tendon. So you're going to feel like a guitar string, which is typically what you're going to hear, and you can really feel the tension in that tendon, and you want to cut across until you don't feel any tension anymore. And if you really need to, you can cut the superior one as well, but usually that inferior one is enough really to release the tension of the orbit. you may actually find some blood starts to come out. Feel free to let that come out and decompress. And these are patients who, if you have done it really quickly and you have done it early enough, you will want to repeat the sort of assessment of their optic nerve, repeat their pressures, and you might actually hopefully find an improvement in these patients' symptoms. In a way, what's funnily enough is actually orbital fractures are sometimes protective of having an orbital compartment syndrome because their compartment becomes bigger. So having an orbital floor fracture can sometimes prevent orbital compartment syndrome. So in a way, it's actually protective to the patient. But regardless, if you have somebody where you are concerned that they have an orbital compartment syndrome, you want to be trying to do a lateral canthotomy and canthalysis quickly. No one is ever going to blame you, or no one really should ever blame you for doing one, because actually they heal very well. And sometimes in elderly patients, you don't even need to go in and repair it. It actually heals beautifully. And if you do need to heal it, it's just a bit of surgery to heal it. No one, that's not problematic. What's much more problematic, it's damage to the optic nerve because nobody did anything, and that's irreversible. We can repair a lid, we can't repair an optic nerve. So you really ought never be blamed to doing one of these, and feel free to have a low threshold in performing a canthotomy canthalysis. But typically these are performed by the emergency team, so you may not always be in a situation where you're the one doing this. But again, even though it's uncommon, it's one of those things where you don't have a lot of time to prep for it. So regular reminders of how to do this and what equipment you need is helpful. So in summary, we've gone through the lid lacerations, we've spoken about how to close margin involving defects, and we've also spoken about the orbital fractures, how to approach them, what to assess, and what sort of fractures are ones that are going to indicate early intervention with surgery, either with your MaxFax colleagues or with your orbital colleagues. And we touched on how to do a canthotomy canthalysis. In future sessions, I'll discuss kind of, lid masses and the reconstructions of the lids, but really today's session was more to do with our urgent eye care series and talking about your sort of orbital and lid lacerations that come across. In future sessions for urgent eye care, we'll talk about things like corneal foreign bodies, your penetrating and your blunt injuries. But hopefully this was a nice reminder on how you approach your lid lacerations and orbital fractures. So just another reminder, please do give some feedback. It really does help me. And thank you very much for joining, and we'll see you at the next one.